Welcome to the urology consultation. In this patient-doctor consultation, we are going to discuss Rebecca's presentation. Rebecca is a 24-year-old lady with 2 years history of frequency, urgency, pain in the bladder, and getting up at night at least twice to empty her bladder. She has submitted several urine samples to her GP, which did not reveal any evidence of urine infection. Rebecca has a history of irritable bowel syndrome, and this is controlled with laxatives and high-fiber diet. Otherwise, she had no other medical problems.
Good morning, Rebecca.
Good morning, doctor.
So, tell me about your waterworks symptoms.
Thank you, doctor. My symptoms have been going on for quite a long time. I have always felt that I needed to go to the toilet more often than my friends, but the symptoms have become particularly worse in the last 2 years or so.
Okay, what are the symptoms that bother you the most?
I am bothered by the need to go to the toilet every hour or so, which is wearing me down. I am also bothered by the painful sensation of my bladder, and sometimes I drink more to try and dilute my urine as I feel that this helps with the pain. Having said that, the more I drink, the more I need to go to the toilet, which is a vicious circle.
Are there any types of food or any triggers for your bladder symptoms?
Thank you. I haven't paid a close attention, but I think spicy foods and onion don't agree with my bladder.
Have you seen any visible blood in the urine?
No, I haven't.
Okay, looking at your urine cultures, I can't see any evidence of infection. Your symptoms could be a combination of two conditions, and sometimes they coexist. The first condition is bladder overactivity, and the second condition is a painful bladder syndrome.
What is an overactive bladder?
An overactive bladder is when your bladder tries and squeezes on its own accord, which gives you the urgent sensation of needing to go to the toilet without necessarily having a full bladder. It is not fully understood why this happens. Certain food or drinks could make this worse, and the more you drink, the more you are going to need to go to the toilet.
I see. How is overactive bladder treated?
For this condition, it is recommended to adopt a behavioral therapy approach. This entails restricting your fluid intake to 1 liter or 1.5 liters a day. It is also recommended that you avoid fizzy drinks, Coca-Cola and coffee and tea. Caffeine is a bladder irritant, and it is also a diuretic which makes you produce more urine and therefore go more often to the toilet. Pelvic floor exercises could also help to strengthen your pelvic floor muscle, which would help you control the urges better. Bladder training is another strategy that might help, where you try and void at certain set times and resist the urge to void in between those set times and gradually try and increase the interval between those set times. This might help to increase your bladder capacity.
Okay, thank you, doctor. What is primary bladder pain syndrome, and why are you suspecting it?
Primary bladder pain syndrome is a chronic inflammatory condition that causes you to have a sensation of urgency to go to the toilet, which results in frequent visits. You might also experience bladder or abdominal pain, which sets this apart from an overactive bladder, which is often not painful. The pain is often relieved when the bladder is emptied. Patients often wake up at night to urinate as well. Extreme cases of bladder pain could present with ulceration and scarring of the lining of the bladder, which can result in a reduction of the capacity of the bladder and might cause back pressure on the kidneys. However, most cases of bladder pain are not associated with ulcers.
What causes this condition, doctor?
There are many theories. The most widely believed theory is the mast cell activation. Mast cells are a type of white cells that can be found around the bladder muscle fibers or around the blood vessels. For some reason, the mast cells are activated in this condition, and this results in a release of histamine, which is mostly responsible for causing the pain sensation, and in some cases could cause the bladder tissue to become fibrotic, which results in a loss of its elasticity, as well as a loss of capacity. The second widely believed theory is the deficiency in the gag layer. This is a protein layer that usually covers the lining of the bladder as a protective coating. And in patients with bladder pain syndrome, this layer is deficient. The latter results in urine escaping deeper to the lining of the bladder and irritate the muscles of the bladder. There are other theories like the neurogenic and autoimmunity theories, but I don't want to complicate this too much for you.
Thank you, doctor. How do we find out if I have this condition?
Most of the diagnosis is based on the history and the symptoms that you are describing. However, we often recommend a camera inspection of the bladder under general anesthetic to rule out any anatomical abnormalities and perform a procedure called hydrodistension. This entails filling the bladder to maximum capacity for 3 minutes and then emptying the bladder and looking for certain signs like glomerations, which are small grape-like bleeding that could appear under the lining of the bladder after emptying. We could also obtain some biopsies of the bladder during the procedure to study those under the microscope and look for the presence of mast cells.
Amazing, doctor. Thank you for this great explanation. Okay, could I ask what are the treatment options for this condition if found?
Thank you. There are different treatment strategies for this condition. There should be a multidisciplinary team approach throughout, from physicians, dietitians, physiotherapists, pain specialists, psychologists, and patient support groups. Patient education and support is of paramount importance. This entails teaching the patient to do bladder training and help the patient with stress management, pelvic floor relaxation techniques, and referral to the pain team. Also, the patients are advised to avoid individual triggers like coffee or citrus fruits, for example. The patients are also encouraged to have realistic expectations, as this condition is chronic and the symptoms can persist for a long time despite treatment.
Are there any tablets that could help treat this condition?
In terms of medical treatment, there are few options with strong evidence. The first option is amitriptyline. This is antidepressant tablet and is also a nerve-type painkiller. It can be associated with drowsiness, which can sometimes limit its use. The second option is a tablet called pentosane polysulfate, which is a semi-synthetic drug manufactured from beechwood hemicellulose. The response rate is around 50%. There are other options with weaker evidence, which include bladder installation therapy, where a small catheter is introduced into the bladder temporally and a small amount of fluid is inserted inside the bladder. Then the catheter is removed, and the patient is encouraged to keep the fluid in for 90 minutes and then void. The fluid replaces the missing gag layer. Failing bladder installation, the last option is Botox injections inside the bladder, which has good evidence behind in those cases where the installation fails.
Thank you very much, doctor, for these insightful comments. I do feel that I understand the condition much better, and I am happy to have the investigations and the recommended treatment.